Welcome to Feed Your Lion. I'm Dr. Jan, and I'm here to aid you in the mastery of total health, spiritual, mental, emotional, physical, and financial. So prepare to have your wellness tank filled up with this podcast. All right, welcome back to another episode of Feed Your Lion. Today's special guest is Jan Rader, and she is going to talk to us a bit today about substance abuse and all the issues surrounding it. She's had a ton of experience with this, so she's really going to help put some light on the subject. So, Jan, tell us a little bit about your background, your career, your experience, because you've had a lot of it. So go ahead and tell us the highlighted portion there.
Okay, well, my name is Jan Rader. Currently, I'm the director of the Mayor's Council of Public Health and Drug Control Policy for the City of Huntington. Prior to that, I worked for the fire department. Rose up through the ranks. The last 5 years of my 27-and-a-half year career was spent as the fire chief. I'm also a registered nurse, and back in the day I was an old paramedic. But I grew up in this area. I grew up in Ironton, Ohio. So actually watched the substance use disorder issue unfold from two views, that of a firefighter, a first responder on the ground, and that of an emergency room nurse, because I worked on my days off at Cabell Huntington Hospital for years.
So you did 27 years in the fire. Was that before or after nursing?
I did it at the same. I was an old paramedic, and I was one of those that thought, all right, I don't want to ride in the back of an ambulance when I'm in my 50s and I retire. So I went to nursing school at age 40.
Wow.
So
that's awesome. I love it. So you've literally done like all of the things, like firsthand things with drug addiction and all of that. You've seen it all.
I've seen a few things.
Yes. Yeah. So tell me a little bit, like, how's it changed from when you started out to like now in this area? Like we're in, the tri-state, so we're talking Huntington, West Virginia, Ashland, Kentucky, and then even like Ironton, Ohio, Portsmouth, Ohio, that whole area, that tri-state.
Yeah, so, when I began my career as a first responder, it was August of 94. And for the first, few years of my career, I didn't see a lot of death. When I did see death, it was usually an older person who had a heart attack or a stroke, or maybe I saw an occasional car wreck where we had a young person die, or a motorcycle wreck, and occasionally a SID baby or something to that effect. Yeah. But the thing was, we had time to recover from it. Sure. It wasn't all day, every day, and we didn't see a lot of overdoses whatsoever, and if we did, it was usually alcohol induced. And then in the early 2000s, we started seeing prescription drug overdoses, and how we knew that is there were pill bottles laying around. Sure. And then people moved on from just pills to snorting it and shooting it. We would find utensils for IV drug use. About 2010, 2011, there was a big crackdown on pill mills or bad physicians, if you will, that were prescribing without a reason. And, that big crackdown led to people who were suffering from substance use disorder moving from a metered known dose to the substance that was readily available, which was heroin.
And it was cheaper, too.
It was cheaper, it was unmetered, but it was using a needle, inviting bacteria and all kinds of bloodborne pathogens into the body because of sharing and the habits surrounding that. And that switch happened probably 2010 to 2012. A lot of people that were suffering from substance use disorder in this area became hooked from a legal prescription. You had doctors out there that were prescribing what they were told was a less addictive or non-addictive product over the years, and not really understanding it. There was a lot of false advertisement and things like that. But once people here could not get their pain medicine, they would go down to Florida to pill mills and buy thousands of pills and bring them back. But what really affected Appalachia in general was the pill mill bill that went into effect, I think it was in 2011, and it shut down pill mills in Florida.
One of our local docs was a big part of that, wasn't he? Like
We had several.
Yeah, I was going to say.
We had several.
Yeah.
We had quite a few, actually, in the area. And one of the biggest pill mills for a while was in Portsmouth, Ohio.
Yeah.
So when the pill mills were shut down, people, a lot of people not understanding addiction thought that the problem would just go away.
Yeah.
And it didn't. It actually got worse because of changing from that metered dose to that unmetered dose, and then the complications medically surrounding IV drug use as HIV, hepatitis B, C, syphilis, things like that. So it's interesting where we are now.
Yeah.
The product on the street is always changing.
Yeah.
Obviously, to affect greater change, we must focus on getting people help that are suffering from substance use disorder. But I will also back up and say, in my department and in the emergency room where I worked, we saw it going from just a few overdoses here and there to constant. And in our height, or our peak year so far in, better knock on wood, in 2017 in Cabell County and Huntington specifically, the average first responder was probably seeing up to 5 young dead bodies a month compared to,
like rarely ever.
Right. So there's, a lot of differences to being a first responder today, because you might be responding on the overdoses and the deaths of your classmates and your friends and maybe even a family member versus, what I saw coming up through the ranks, which was Mama and Pawpaw dying of
old age things.
Exactly. So it's a different world out there for our youth today.
Well, and you said, all the complications with the IV, but even they don't even know what they're getting half the time. And a lot of them now, they mix these, they try to make it cheaper on the drug dealers, right? So they're formulating it with a bunch of stuff. You don't even know what you're getting in there.
They try to increase their product margin.
They're great business people, these drug dealers.
They are. Most of what's on the street now is polysynthetic, and probably the majority currently is like meth, very strong methamphetamines mixed with fentanyl, which poses even greater issues, because you have patients or people suffering that just want heroin, and they're told it's heroin, but they quickly find out that it's not. Let's say they overdose because it's fentanyl related, and it takes multiple doses of naloxone to get them back. Now they just have meth on board on the receptors, and that's causing a lot of temporary and long-term psychosis.
Yeah,
a lot of mental illness increasing because of the product on the street.
Now, let's back up for a minute, because you mentioned the naloxone. So explain to people what that is for those who haven't had any experience with this.
Okay, great. So opiates make people high, or they, cause euphoria in the body. They adhere to specific receptors in the brain. And you're probably more versed on that.
The mu receptors, yes.
Yeah, and delta maybe?
Yes.
Mu and delta, okay.
Yeah.
And so what that also does is it suppresses the respiratory system until somebody stops breathing. So if somebody overdoses from an opiate, which is heroin, it's a whole group of drugs, they can die within 5 minutes if they stop breathing. And so you have a very small window of time to save that life in that moment. Naloxone is administered several ways, intranasally or by a shot intramuscularly or through IV. And that actually knocks the opiate receptors off the receptors, causing the respiratory suppression, so people start breathing again and then wake up. So it's a miracle drug when it comes to somebody who is overdosing with an opiate on board.
Yeah, and I like to tell people too, this was always something they pounded into us. The naloxone tends to wear off quicker than the actual opiate. So somebody can be, you give them naloxone and suddenly they're back from the dead. They're, it's like they never even took the stuff. But then you wait like 45 minutes or so and you can see them start to go down again, because that opioid effect on some of these lasts a lot longer than the naloxone. So that's something too, if you were ever in a situation where you're giving somebody naloxone, because you can carry it now. I mean, anybody can
Anybody can get it. We always advise that we encourage the person who overdosed
to go to the hospital,
to seek advanced medical care.
Yep.
Many refuse, but that is something that we push.
Yeah, absolutely. So since we kind of talked about that a little bit, is there any story that, I know you've seen everything under the sun with your career, but is there any stories that you've heard or that kind of surprised you or shocked you or kind of changed your view on some of these things?
Well, as a first responder, and for years when I worked in this field, there's a lot of negativity and stigma surrounding substance use disorder. In fact, that's probably the number one barrier to somebody getting the treatment that they so need. And many people want it, but they're treated so poorly by the medical community that they won't go to a hospital or they won't go to certain places for treatment. So we're trying to change that narrative. But I will say this, I understand why people think that or have those negative views. I try to see every side of it.
Sure.
It's very frustrating if you're a first responder to be on the same person overdosing over and over again.
Absolutely.
I remember one day in the emergency room at Cabell that I helped revive the same person 3 times. Okay, so we put him up in the ICU the 3rd time, so that at least his body can rest and hopefully that he will decide to get the help that he needs. Because each time you revive somebody, that's another chance at recovery should they choose to take it. And so that's our whole goal. But there for years I didn't see a lot of people in long-term recovery. And that's one piece that I think is missing. I think the medical community at large and first responders need to interact with people in long-term recovery. That gives them hope and cuts down on their frustration.
Sure.
And that happened to me, working both sides of it. I finally was like, look, you don't have a lot of time in an emergency room, but I started trying to take the time. How did you get to where you are?
Sure.
And you find out that there are, probably 80% of the patients that you deal with are started with a legal prescription. Maybe they had a bad motorcycle wreck. Maybe they had a burn. And by the time they left the hospital, they were addicted to a pain medication and not given any advice or help in tapering off of that. And so here they are. Now they stick a needle in their arm so they're not dope sick.
Yep. Well, it's easy. I mean, it's easy when you're in those kind of fields and from the emergency room standpoint, you see this stuff over and over again, and it is exhausting and draining sometimes. So you're right, kind of trying to personalize that a little bit and remember, hey, we're treating humans, we're treating complex people who all have a different story, and kind of trying to get, I understand what you're saying, because I think it's easy to just kind of put on those blinders sometimes when you get in those fields to just.
So, I have many friends now that are in long-term recovery, and I've sought that out, and I am happy to work with the recovery community as part of my job. But it changes your mind when you learn the backstory of someone and you're like, wow, people do recover. Many people recover, and they do extremely well.
Yeah.
And I think that needs to be highlighted for just the general public and the medical community as a whole.
Is there any other common misconceptions you see around people that you work with besides that dehumanizing kind of?
Well, I think a lot of people, it's interesting because let's take an overdose, for instance, and break it down. There is nothing positive about an overdose. Somebody calls 911 because their friend has collapsed. Okay, we get there, and you might have 4 or 5 big burly men hovering around somebody. They give them naloxone nasally, And then when they wake up, they're standing over them. They're not being mean. They're just saying, you overdosed. You could have died. Out of concern, they got a lot of adrenaline going because they're trying to save this life. And then that person is offended by that attitude or what they think is attitude. And they're also embarrassed, so they might say a few bad choice words to the first responders. And then the first responders are mad because the person is ungrateful that their life was saved. So it's a very negative encounter. So in Huntington, we're trying to change that because we started a quick response team, and they go out within 72 hours of the overdose, and they offer that person who was revived different methods to get the help that they need. And, so now they've had this negative encounter where they think first responders hate their guts, and now they have a police officer and a paramedic knocking on their door saying, hey, we want to help you. We don't want you to die. And it's changing their view of us as well. So it's a good thing.
Puts a positive light on it. I got you. I love that. I love what you guys are doing. So as far as, let's talk about real quick, I haven't mentioned this yet. You were on a Netflix documentary talking about this. So tell everybody the name of that, how they can find it. It's on Netflix, but and talk about your experience with that a little bit.
So that the documentary is only 39 minutes long. It's a short documentary, and it's called Heroin with an E in parentheses at the end. And it basically follows three of us ladies in Huntington trying to do positive things for our community. So it highlights myself. At the time, I was a deputy chief when they first started, and then I became chief during the filming. So a firefighter on the front lines, Nisha Freeman, who is a street minister. She's a realtor by trade, but she ministers to prostitutes on the street. And then the drug court judge at that time, Judge Keller. And so it kind of happened by accident. We had some filmmakers from West Virginia who were losing their friends to overdoses, wanting to film. They came to Huntington. The mayor's like, yeah, absolutely, let them film. And they followed us around for a little while and found some funding. And then they called us later and said, oh, by the way, Netflix is picking it up. We didn't think it would be any big deal. But it turned out to be a little bit of a big deal. And I think that what it did was give families who have somebody special suffering from or who has died from addiction the opportunity to talk openly about a very stigmatized issue. And I think in that way it's been very positive. So
now, did you have any other, like, you got to do some other things off of that too, right? Like from as far as working with this issue?
I did. I think I got to do a TED Talk. TED Women reached out to me. A curator from TED Women reached out to me. I kind of blew her off for a week or so because I thought somebody was punking me by sending me an email. I thought, they don't really want me to do a TED Talk. But I actually did it, and I'm glad I did it. Doing a TED Talk is hard, but it was a very positive experience. And if it can do some good, by highlighting what we're doing in Huntington. Hopefully, we're all for it to support it.
So as far as how do people find your TED Talk if they want to watch it?
If they just Google Jan Rader TED Talk, it'll pop up. It'll pop up.
Okay. As far as like the general public, because we've talked a little bit on the provider side or frontline people. As far as some of those misconceptions or things you wish people like in the general public who may not have had any personal experience with, I feel like in this area everybody's had somebody close to them that they know that's had a drug issue because it's such a prevalent thing. But somebody who may not have had any close experience, what's something that you would want them to know about that they...
Well, these people suffering from substance use disorder, they have a disease. They have a brain disorder that changes their thinking and is difficult to manage. But it is a medical condition that can be dealt with. The autonomy of medicine tells us that we let the patient decide, though. And that's where the difficult part comes in. Now, you know, people don't have a stigma surrounding like diabetes or high blood pressure or other diseases. Are they as tough to manage? No. But I will say, as a nurse, I have yet to find a patient who is totally compliant with what the medical community tells them what to do. But what I find is the general public in general, you know, generally wants people suffering from addiction to do the right thing.
Yeah.
But we don't expect that out of people who smoke or have diabetes and other issues. So is it difficult? Yes. Is it manageable? Very much so. But I would say do some research, you know, reach out to people that are very well versed in this area, and they can help you with information.
So as far as, I hear a lot of people say, and I'll be honest, when I first like started studying with this, you know, you hear people say, I don't like that they call it a disease because they're choosing to start. But I think we call it a disease process because, like you said, it's actually altering the chemical makeup of the brain. I mean, that's why, right? Am I wrong in that?
No, actually, you're very right in that. But here's the thing, you know, Uncle Sam gave out smokes to soldiers.
Yeah.
And then they became addicted to nicotine. Okay. We had good intentioned physicians writing prescriptions for pain medication that led to a lot of people suffering from addiction. Now, is there a percentage of those that are suffering from substance use disorder that chose to do it?
Yeah.
Yes, but once, I mean, I'd hate to be held responsible for all the stupid things
I'm with you. I'm 100% with you. That's another thing. Do you think that it's gotten so prevalent because of that hike in the prescriptions? I mean, do you think that, or what do you think that is that made that switch from early on where we didn't see it? Like, what do you think?
I think
a combination?
I think that's the biggest part of it is the prescription drug epidemic that led to this. Now, you know, probably, you know, and I don't have hard facts and I don't have proof. It's just my own experience. I'd say about 20% of the people that I deal with started with drugs because of trauma. They're trying to numb. But I've seen some horrific cases. You know, I just dealt with, I spend one day a week working at Harmony House as a nurse with a physician who donates her time to provide free medical care for the homeless. And, you know, some of the stories are tragic. You know, if you, at 8 years old, were shot up with heroin from a family member, you know, what
kind of quality of life are you really going to...
Exactly. Yeah, exactly.
Yeah, no, I'm with you. There's some terrible things out there.
Absolutely.
Like it's amazing when you talk to some of these people about the stuff they've been through that they're even still standing half the time.
Exactly.
So let's move a little bit. Well, first, you might know this book. There was a book written about the actual prescription thing down in Florida you were talking about earlier.
American Pain?
Yes.
It's a great book.
That is crazy. I read that story, and it talks about, I mean, the guy who started those, like, clinics and handing it out, he wasn't a physician or anything. He was like a contractor or something, right?
Well, no, actually, he was a criminal. He was a felon because he moved and sold antibiotic or steroids.
Yes, but did he work like as a contractor or something?
I think he did.
But it was crazy. Like he I remember he like rented out this huge bank, and they just had garbage fulls of like cash, and they found physicians just to like come and write these. It was like the craziest thing I've ever read.
That's a good book. Also, Dope Sick by Beth Macy is a really good book. They made a Hulu series out of it.
Okay.
It's an 8-part series on Hulu, which is very realistic as far as the general public can tolerate.
Yes.
And she just released on the 16th of this month the follow-up book to that called Raising Lazarus, which is fabulous. And it talks a lot about what's going on now.
Okay, those are good. So those two books are something to check out. But I got to read that other series because I didn't. But I was like fascinated by that first book. Just it's the whole backstory to like the pain prescription pain pill mills, all that stuff. Like it's really fascinating stuff. But people they were coming down from Ohio, Kentucky, straight on down, and just coming back with like months full of pills. Like
yes, it was John Temple who wrote it.
Yes.
He's a professor at WVU.
Yes. That was fascinating. But anyways, so going back now, we've talked about people who may not have experience. What about family members? What are some things you would suggest with family members? And specifically, you see a lot of enabling behaviors,
You do.
I feel like, with family and drug-addicted populations.
I think it's imperative to, and it's a fine line, you need to set good solid boundaries with your loved one who is suffering from substance use disorder. You know, I don't excuse the criminal behavior surrounding substance use disorder. The theft, committing significant crimes, especially violent crimes. People need to be held accountable for those crimes that they commit. So a lot of family members deal with a lot of theft and things like that. I think it's imperative to set good solid boundaries. Another thing that I suggest that all family members do that have a loved one suffering from substance use disorder is learn how to use naloxone and keep it handy.
Sure.
At all times. That gives you a little peace of mind that if they would overdose under your roof, that you could assist in saving their life in that moment. So again, maybe they can get the help that they need.
Well, and she mentioned earlier, but like some of the fentanyls, it can take tons and tons of Narcan. I mean, like with a heroin, you can do, a shot of Narcan, you're good usually, for that initial part. But with some of the fentanyls, it's so like strong, and
it is.
You can. I mean, we've been in the ER given round after round and barely keeping them awake.
I've seen a couple drips before in naloxone.
Yes,
in an
Narcan
emergency.
drip, absolutely, which is like more continuous dosing. But so that doesn't even absolutely have it, but it doesn't. Depending on what they're using, sometimes
You always got to call 911.
Yeah.
Immediately.
Yeah.
Use the naloxone, and calling 911 gets more help there that can assist and bring more naloxone.
So we talked about, some of the behaviors of thefts and things like that. What's something like if a family member might suspect something, what are some of those common behaviors that they should watch out for?
A lot of times they're, when people are high on a narcotic, their pupils become pinpoint. They might nod off. You might have behavioral changes, change in moods. If somebody, some of the early signs of a family member knowing that their loved one is suffering is seeing them dope sick. Okay, so by dope sick, their body is reacting to not having the drug in their system, and they become doubled over with nausea, stomach cramps. They'll have excessive diarrhea. They'll have body aches, and a lot of them have a spike in temperature. But those are signs of dope sickness, which is, people describe as the flu times 10. And it's actually painful to watch somebody going through withdrawals.
Yeah.
So dope sickness is withdrawals from that drug because they don't have the product.
So that would be another thing somebody could watch for. So what are some resources, like if somebody wants to get help, like what's out there for people right now? Like what are some of the common things you see, and how hard is it to get into these places?
Well, so, you're seeing more and more facilities open up. I would suggest researching what's available in your area. As far as Huntington's concerned, we have something called ProAct. It's a freestanding facility that's open 8 to 4:30 every day, where you can go in and get help within a couple hours if you are really wanting to get that help that you need. You have mental health agencies around the tri-state area. Some people go in through like sober living homes. So it just depends, and there are different models. Some people choose to use medically assisted treatment, which is Suboxone or methadone. Vivitrol
Yeah.
is another big one to deal with cravings that you have.
And the Vivitrol is just making it so you wouldn't have an effect if you were to take it, or you're blocking
Correct.
those receptors. So it's like they're gonna get the shot like once a month, and it's gonna be a longer acting, like the Narcan that we've been talking about. It's
Yes.
kind of a longer acting. It's blocking those receptors, so they wouldn't have that. So you're blocking those receptors with it for a longer period of time. But I want to know your thoughts on the Suboxone methadone. Like, what are your thoughts on that? Do you think that's a good thing for people, or versus like an abstinence based?
Well, I think that everybody is different. Okay, so what works for me may not work for you.
Sure.
I think that Suboxone and methadone are great ways to stop sticking a needle in your arm, because if somebody is shooting up an unknown drug every day, multiple times a day, they are sharing needles, they are spreading bloodborne pathogens, they're
Sure.
inviting bacteria in their bodies. The cases of endocarditis are off the Richter scales. You got young 25-year-olds getting heart valve replacements because of the vegetation on their valves from the bacteria.
Yeah.
So, people can function and live a normal life on Suboxone. It also comes with counseling on a regular basis. I love the combination of a drug plus the counseling. That way they can over time taper off that Suboxone. But I know that there's many people who have been using so long that they might be on a maintenance dose of Suboxone the rest of their lives. So what's the difference from taking high blood pressure medicine versus taking Suboxone to stop you from sticking a needle in your arm?
Well, and there's a lot of stuff still though, if they're on that long term, that they can't get, right? Like I know, like life insurance, they can't get some life insurance if they're on Suboxone. Now they can if they're off everything.
Right.
With a history, but not currently taking. And then I know like stuff like in this area it's big because everybody likes their guns, but like concealed carry and stuff like that, they can't have that. Same thing with the medical marijuana card. I mean, it's the same, but I don't know. Like
It would be a start, though.
it would be a start. I worked in it for a very short period of time because I honestly just wanted the experience to see. And I do think there are those clients that did very well with it and stayed on it. But there's also a lot of like diversion and stuff issues with it. And for those of you guys who have never heard of like Suboxone or any of that, it's a drug that works on some of those receptors, and it's what we call an antagonist and agonist. So it's got mixed effects. So it works on some receptors and not on others. It's kind of hard to explain in a generic sense, but it basically can still give them the high feeling to some extent. Not like a heroin or something to like that, but it's still going to give them a little bit of effect. But it's basically to keep them from, like she's saying, not use the IV form and to be more controlled with it, more regulated with it. But there's a lot of, I think even in the medical community, there's a lot of arguments about the best way to do that, because you've got those advocates who say they should be on it forever and stay on it. And you have people, like I've met other physicians who think that way. And then there's the other people who are like, no, the only way is like an abstinence base. So I feel like there's a lot of, argument in there. For me, I think shorter term is fine. I'm not necessarily, I have seen those people that are on low dose forever, but to me, I'm like, what are they really doing with a little tiny dose of Suboxone? It's not really, from a physical standpoint, it's more of that mental, like dependence on it. Would I rather have somebody doing that than shooting up every day? Sure. But it's kind of I don't know.
I think it's also one of those things that we're just now getting into the realm of advanced research in this area to show us what is best for the patient. But I think it's a good start, and there is diversion. But I've talked to patients who say, well, I buy it on the street because I don't want to stick a needle in my arm, and I'm on a waiting list to get into a Suboxone clinic.
Yeah. I know it's tough. There's not, and like you said, recovery is so personalized. Like everybody's so different, and their stories are so different. So it's not like a one size fits all with a lot of this stuff. So
And a lot of the abstinence-based programs are actually religion-based,
Sure.
and a lot of
People
people
don't want
are
that
really
either.
turned off by that. So,
no, you're right. It's like I said, there's still, I feel like, a lot we can all learn about
Oh, yes.
like approaches, but there is. I mean, you've got inpatient, traditional inpatient, where they can detox them that way. You've got all these outpatient clinics where they go for the counseling. They can do their Suboxone or methadone that way. You've got these transitional homes or these sober living homes where people can go. So there's a lot out there, and I've heard of people that do it on their own too. I mean,
Me too.
Even today in Rotary, we had a speaker who was a recovering addict in 6 years. Did it on her own. Like, so I just feel like there's so many different stories out there.
I spoke to a gentleman the other day he got clean in prison. He was
Yeah.
in prison for 6 years.
Yeah.
And he said, I could have had drugs every day of my incarceration, but I was never going to be back here. I
Yeah.
wanted to get out as soon as possible, and I was never going to be back. And he was clean the whole time in prison.
Yeah.
That did it for him. And now
Yeah.
he's out, and he's married, and he is a father, and makes a good living. And
Yeah.
he's a testament to doing it on his own.
Yeah, exactly. So, is there anything on that note that you think we could be doing better? Like what are some of those things you think we really need to improve on?
I think that the stigma part is where we really need work. And, I think that we need to realize, I think, part of the stigma is associated with the war on drugs. For 50 years we've been taught drugs bad,
Yeah,
drugs bad.
yes.
And I think that's a big part of it. So it's not a moral failing. These are good people that have a condition that needs to be medically treated. And we need to make sure that we treat everybody with dignity and respect. It always, cracked me up, or not cracked me up, it just kind of showed you the differences in how patients are treated, when you'd have somebody come into emergency room or be dealt with in the field by first responders. Let's say they're having a diabetic emergency because they're refusing to test their blood.
Yep.
They're refusing to follow dietary restrictions, and they're not using their insulin properly. Okay, we treat them with dignity and respect. We joke around with them, and
Yeah.
they might be obese. They might have eaten a whole
Yeah.
cake instead of a sliver of a cake.
Yeah.
Okay, but then you have somebody, or say you have somebody that has lung cancer that smoked for 35 years.
Sure.
We joke around and treat them with dignity and respect.
Yep.
But that person who overdosed, why do we have to treat them differently? Just because we don't understand it. I feel like we need to educate the general public. We
Sure.
need to educate first responders and the medical community more. And, our job is to save lives. It's not to judge,
Absolutely. Absolutely. I think that's a great place to kind of wrap up the discussion. I mean, honestly, that's just treating people well.
Absolutely.
The golden rule, right? All right. So anything else that we didn't really talk about or cover that you want to add on before we kind of close it up?
No, I appreciate you inviting me on your podcast.
It's fun.
It's great.
I love it. I love it.
Keep on doing great things.
Well, tell everybody again where they can find you if they have like any further questions, or if they should call the health department in general, or
Yes.
where they can look you up.
I'm easy to find. I work for the city of Huntington. My email address is raderj@huntingtonwv.gov.
Okay. All right. So as always, we'll wrap up with our quote, and today's is, if you find yourself in a hole, the first thing to do is stop digging, and that's Will Rogers.
I love that.
Until next time, guys.